Hello everyone, this is Dr. Sendhil Kumar from Gateway Clinics, Coimbatore, India. Hope everybody is doing good. I think you have seen my previous video about laparoscopic TEP repair, and this is the continuation of that video. If you didn't see the video, please see that video also. In this video, we are going to talk about mesh insertion, mesh placement, mesh fixation, and deflation of the carbon dioxide. First, let us see how we are inserting the mesh into the preperitoneal space. After the complete dissection, we actually introduce the mesh through the 10 mm trocar, place the mesh in the preperitoneal space like this, and unfold the mesh and to fix the mesh to the Cooper's ligament. And there are other ways of fixation. You can use either tacks or glue, and the deflation should be done under vision. The peritoneum, you should put two instruments to hold the lower part of the mesh, and you tell the anesthetist to increase the head up tilt, and you can deflate the carbon dioxide from the preperitoneal space under vision, so that the mesh will not get folded. I will show a small video here. In this small video, you can see the bilateral TEP repair. You can see this is the incision, and we are using an artery forceps to enlarge the incision which we have made to the anterior rectus sheath, and the camera port is introduced between the rectus muscle and the posterior rectus sheath, and we have started insufflation already, and this is the view which we are getting with the 0-degree telescope. Don't go anteriorly like this to enter into the rectus muscle, and go slide your telescope along the posterior rectus sheath, and then change your direction of dissection horizontally, so that you can place an incision for the first working trocar, and you can appreciate the first working trocar is entering into the dissected area. This entry will be lateral to the inferior epigastric vessels. Now this is a bipolar instrument. You can use it for coagulation as well as cutting, and we are just crossing the midline. Now I am holding the camera as well as the dissection instrument. The next actually aim of this one is to create space for the insertion of the second working trocar. So you can see this seals and cuts. So that is the main advantage. The camera is held by the surgeon, and the instrument is also held by the surgeon. So with good coordination, we can work for some time before the camera is given to the assisting surgeon after insertion of the second working trocar. So once you are in proper plane, then you can nicely expand the plane as much as possible before planning for the second trocar. So this is at the midline. We are actually working here at the midline, and as you go and dissect, the bladder will automatically move down. So that is how we have to dissect the hernia, preperitoneal space. This step can be done by using a balloon dissector. So here, if you place the balloon in this plane, and if you insufflate it nicely, this part of the dissection will be done by the balloon itself. And here we are doing this dissection under vision. That is the main difference between the balloon dissection and this dissection. So if there is any preperitoneal surgery like prostatic surgery or any surgery done in the preperitoneal space, like previous inguinal hernia surgery with laparoscopic approach, this plane will be totally frozen. So in that case, you should avoid using TEP technique for inguinal hernia repair. Instead, you can go with TAP approach. So now with this instrument, we are trying to expose the preperitoneal space as much as possible, and then after that we will be going for the second working port for incision. So we are placing the port similar to the TAP approach. So only difference is here the camera is in the umbilicus, and both the working ports are in the mid-clavicular plane, about 1 centimeter below the umbilicus, horizontal line at the level of the umbilicus. Now you can appreciate the second working trocar is coming inside. Once you have got both the instruments inside, then very easy to proceed further. And this is how we dissect the direct sac. This we have seen a indirect sac in TAP surgery. Here we are showing a direct sac. So once you identify the fascia transversalis, if you are able to identify the fascia transversalis, if you stay in the plane, correct plane, if you stay in the correct plane, you just pull the peritoneum and preperitoneal fascia and fat with your left hand and push the fascia transversalis away from the peritoneum by using the right hand. That is how you have to separate the hernial sac. You can see nicely going away. With the carbon dioxide pressure, this divided pseudo sac will move away, so that you'll have a beautiful exposure of the field. So after completing the direct sac dissection on the left side, we are coming and doing the dissection on the right side. This is right direct hernia. If sometimes you will be having bladder as a slider, urinary bladder will slide into the hernial sac. So again, there is no difference in dissection. You stay on the fascia transversalis plane, stay on the pseudo sac. Automatically, whatever may be the slider, it will fall away. So that is how we have to dissect the direct sac. So dissection of a direct sac is very easy. And after dissection of the direct sac, you should not leave at that place. You have to dissect at least 2 to 3 centimeters, minimum 2-3 centimeters below, so that the mesh will have a very nice overlap inferiorly. So you just dissect beyond the corpus ligament at least for 2 to 3 centimeters down, so that the mesh will come and sit there, especially in a direct hernia. If it is a unilateral hernia, then at least you have to dissect at least for 3 to 4 centimeter away from the midline, so that we can place a nice overlap, mesh overlap. This is how we can appreciate. We are using a nice traction with the left hand and counter traction with the other instrument. So here you can appreciate we never hold the cord structures, and it should not be held with any instruments. And another point which you can see, there is a peritoneal rent. There is no need to be worried, because we have completed the dissection at least 75%. And other thing is, the fascia overlying the nerves we are not disturbing. We are completely preserving those fascias. You can see the vas difference is turning medially. At one level, it is turning medially. That is, you have to do the dissection at that level. Another landmark which is very useful is vas difference. Vas difference, if you are able to identify, and if you stay medial to the vas difference, the chances of injuring the external iliac vein is not always there. Usually the external iliac vein will be on the medial side and artery will be on the lateral side. You can appreciate the vas difference which is going on the medial side, and this is the right side dissection. You can pull the peritoneum with the left hand, and that actually stretches the tissue, and you just follow the peritoneum until you reach adequate dissection area. You can appreciate this is the only one instrument which we use for the entire dissection. This is the direct hernia. There is a femoral defect or weakness here on the left side. This is inferior epigastric vessel. The vas difference, that is gonadal vessel, triangle of doom, triangle of pain, and iliopubic tract here. And deep area, and you can appreciate the external iliac artery and vein. Vein is collapsed due to the position. So this is how we have to do the dissection in TEP repair. So you can this is a midline. This is corpus ligament on the right side, corpus ligament on the left side. That is the femoral weakness just lateral to the lacunar ligament. That is the lacunar ligament. In between the lacunar ligament and the external iliac vein, you will have the femoral weakness, and you can also nicely see the iliopubic tract here, and indirect or deep ring. That's what we are holding is the iliopubic tract. That is the iliopubic tract, and this is how she is folding the mesh and giving it to us. and mess lies within the peritoneal cavity like this, and already we have placed two 15 by 12 messes inside, and we are unfolding the mess to cover the myopectineal orifice of Fruchard that actually covers the indirect, direct as well as the femoral defect. So now we are taking the mess. We should differentiate medial side from the lateral side of the mess, because lateral side will have a curvature, so that will go on the lateral side, and medial side at the level of prostate will make a cut that will identify that will help us to orient the mess. And once we place on side mess, the option is you can fix the mess which you already placed properly, and you can come back to the second mess, or you can place both the messes together, and then you can fix the mess at the end of the procedure. During placement of the mess, what are the things which you have to notice is there should be adequate overlap on the lateral side. The mess should go up to the anterior superior iliac spine. Medially, the mess should cross the midline. And if you are placing a mess in a large direct hernia, you focus more on the medial side. Make sure that you have got adequate overlap on of the messes on either side. And below also, beyond the Cooper's ligament, you should dissect nicely. You should reflect the bladder down so that the mess can go completely downward. If you are seeing any obturator hernia, you can dissect the space beyond the obturator defect, and you can even take the mess down towards the beyond the obturator foramen, so that obturator hernia also will be covered by the mess. So basically, this is the advantage of a laparoscopic hernia surgery, where you can cover indirect defect, direct defect, femoral defect, and obturator defect, if it is there also, will be covered. So we always, from day one, we always suture the mess. That actually reduces the cost of the hernia surgery, and the only thing, it needs some expertise in handling the sutures. You have to practice whenever there is any opportunity to do suturing practice. You try to do it, and you can see we are making one stitch already we have made to the right Cooper's ligament. The second stitch we are making to the left Cooper's ligament. There is beautiful overlap. And below also we have already confirmed that the dissected area is more than the size of the mess. These are all the things which you have to make sure before deflating the peritoneum, and there should be adequate hemostasis. Make sure that you are not having any bleeding point left without controlled. So you have a good control of the bleeder, and it is better to prevent any bleeding in the operating field. If at all, if there is any bleed, it should be controlled before coming out. So this is how we nicely, you can see a nicely deployed mesh without any folding or anything, and it covers all the potential hernial defects, and the deflation is done under vision with the patient head end of the patient elevated. Two instruments are kept to the lower border of the mesh while deflating the mesh, so that while doing the surgery, it will not get lifted up. This is how a totally extraperitoneal hernia repair is done. I hope that this video will be very useful for the beginners to practice TEP repair. We are concluding this video now. If you like this video, subscribe this channel. Thank you very much, and see you in the next video.